Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. My name's Derek, your host, and today we have two very important guests in our studio. Today we have Kristi, president of the Academy of Medical Surgical Nurses, and Hayley, a co-host of the podcast of the Academy of Medical Surgical Nurses. Thank you both for being in this studio. If you don't mind, provide our listeners with a brief introduction about yourself.
Well, hi, Derek. I am Kristi Reguin-Hartman. Like you said, I am the current president of the Academy of Medical Surgical Nurses. This is an exciting start to my second year of a 2-year term as president. I have to tell you, the first year just flew by. I remember January of last year thinking, this is a big deal. How am I going to do it? And then here we are a whole year in already. I've been a volunteer for AMSN for a very long time, since about 2012. And I'll tell you, I first got involved because there was an email that came out looking for somebody to help create an award for exceptional Med-Surg nursing units. And I was like, that's a thing. I want to do that. And so I just started saying yes to volunteer opportunities with AMSN for all these years. And then here I am in this presidency role. It's just been a joy and an honor and so much fun in my career. Outside of that volunteer work, I currently work in the IT tech space in a clinical consulting group for Philips Healthcare, and I get to travel to hospitals all across the country and help with nursing workflows. And so that's really fun on my, what I call the paid gig side of my world. So that's a little bit about me. I'll pass it to Hayley.
And hi, guys. I'm Hayley Sweetser. I am a clinical nurse specialist at the largest teaching hospital in Delaware, the Small Wonder. So I have been a Med-Surg nurse for just about the last 10 years. I have spent my whole career, my nursing career, in the Med-Surg specialty, and I just feel so at home in Med-Surg. I started as a student nurse extern, advanced up the clinical ladder, had a quick stint in management, and now I am really focusing on patient outcomes, improving reducing fall rates, reducing CLABSIs, all those things to make patients feel safe when they come to the hospital with us.
Well, thank you both for being in the studio today. We're very excited to have this conversation. And to our listeners, we are going to be discussing the two specialties of infusion therapy and med-surg nursing. So what can we do to work together? And how do we, foremost, create better patient outcomes? Okay, so we're just going to jump right in today. I need to know what the biggest concerns that you're seeing in new nurses being prepared for IV insertion and management of those devices as they enter into the workforce. Are nurses truly prepared to take on that skill set right out of school?
I think my biggest concern is the confidence of the new nurses, especially since a lot of nursing curriculums don't have it as a big part of the curriculum of IV insertions. So they're coming into the hospital, they're doing it for the first time on a real patient, and then the patient, it's very anxiety provoking for the patients. So they're nervous, the nurse is nervous, and then it kind of just sets them up for failure because they're so anxious about it.
Yeah, I think there's so many skills we want a nurse to have experience in coming straight out of school. There's tons of them. And this one in particular, like Hayley said, is kind of particularly intimate, right? Your face is facing the person that you're putting a needle into and, selecting some kind of therapy for. And there's a pain element there. We should totally talk about adult IV pain management versus children IV pain management. I know INS has a great position statement on that, but we're not so good at that in the adult world. And so I think it's a really trialing time for a new nurse. I'll tell you a story, which is before I went to nursing school, I worked as a hemodialysis tech. I had 8 weeks of training. That was my whole training, 8 weeks. And it was really good training, but 8 weeks. And I think now the things I did as a tech, holy moly, right? There was just a lot of risk in them. But one of the things was in that dialysis unit, all the patients sat in a giant circle, right? That's how those setups typically are. And so when I first came off orientation, it was a big test for the first patient whose AV fistula I was accessing. Every patient in that room was watching, right? And that was kind of your test. They gave you one of the hardest ones to start. And then once you had that confidence, then you could move on to other patients. It's just such an, it was such a very memory invoking experience to have to do that in front of a crowd. And we're asking new nurses to do it one-on-one in a really challenging scenario without a lot of that hands-on practice. So I think that part of it is really challenging. How do we fit it into all the things we want nurses to learn?
Yeah, I would agree. The intimidation factor had to be very high. I can remember some of those scenarios as a new nurse myself, thinking back. So many nursing programs provide limited hands-on IV training. What factors like curriculum time, faculty, skill, and resource do you believe most contribute to this limitation?
I think it's a combination of resources and competing priorities. I know for my undergrad program, we were reusing a lot of equipment. So, like when we did Foleys, at the end of our Foley insertions, we would package it back up so that we were saving equipment so that we wouldn't have to have a bunch of new things because they're expensive and it adds up pretty quickly. But also, like you were saying earlier, there's so many skills that new nurses need to know. NG insertions, PEG administration, medication administration. There's so many things that I think, depending on the institution, it might not be prioritized. I went to University of Delaware, and the hospital that I work at right now, Christiana Care in Delaware, they don't have their Med-Surg nurses do IV insertions. So with them knowing that Christiana is the main organization that follows up for University of Delaware graduates, they were not prioritizing it at all.
I think that lack of prioritization is a challenge, right? And I think nursing programs have lowered it on the list because it's a high risk skill, which is such a balance to think about, right? It's a high risk skill, so we want to put off having students do it, yet it's a high risk skill, so we need them to have a lot of practice in it. And so I think that's another big challenge.
I would agree. And actually, I asked you guys this question, but I am an adjunct professor and I teach fundamentals 1 and 2. So I will say that we see these challenges. Absolutely, 100% right. So thank you for bringing that to the light. I know that, INS put out some questions and maybe some inquiry as to what does that look like? How can we better train our nurses within this specialty? Because it's beyond a skill set. I think we sometimes simplify it a little bit too much, but not only are we placing a device, but we're also managing that device, right? Especially within your care setting. So there's so many intricacies that go with it and many things that can go wrong with a device when not cared for appropriately. I will say from a university perspective, I do know that faculty are having the same questions and concerns, and there's lots of meetings and buzzes about it. But yeah, it's a huge issue that we have to address as a profession for sure. This next question is for Kristi. So, Kristi, how is the increasing responsibility for difficult IV insertions affecting Med-Surg workload and nursing confidence?
I think that confidence piece is what we're talking about with that repeated skill and repeated practice. I think we talk about this, it is a skill that needs hands-on physical practice. I think medical surgical nurse workload is a giant priority, and I think we all should be talking about it because we know that a majority of patients in hospitals are taken care of by medical surgical nurses. That's just a population. It's just the largest one. We're the largest one in every hospital. We're the largest one as a specialty. And so we all should be paying attention to the medical surgical nurse workload. This IV skill set and IV insertion piece is definitely a stressor, right? It's something that not all hospitals have an IV team or a vascular access placement assistance resources. And so we have to think about how does a nurse with 6, 7, 8, 9 patients handle those types of things, right? We talk about best practices related to where an IV is placed. Well, sometimes the nurse is focused on getting an IV placed, right? And doing it as fast as possible and as efficiently as possible. The Academy of Medical Surgical Nurses did release new safe staffing recommendations in 2025. And so I know we have members of both organizations that are our listeners. And so it's something that they may want to take a look at as far as a resource to help with that.
So, Hayley, how can infusion nurses and vascular access specialists support Med-Surg nurses?
I think honestly, our vascular access nurses at my organization currently are so wonderful at supporting the nurses. And I think one of the biggest things that they do that really I think is very supportive, especially because I have such a big focus on patient outcomes, is they are rounding for CLABSI prevention. They're providing real-time education to patients and to med-surg nurses so that they understand what the expectations are. And they're really backing up the nurses for if they have concerns about the line, whether it's TPAing, getting it escalated to the provider so that we can remove it appropriately. I think that's the biggest thing, collaborating, but also advocating for the nurse when they think that there's something wrong with it, being that backup level of support.
What about your complex IV insertions? Are you utilizing the teams for those insertions, or are you expanding education to include insertion practice for your med-surg nurses?
We definitely use our vascular access team for our complex lines. They insert almost all of our PICC lines, which is absolutely lovely, and they help prioritize those lines. I think one of best things that our vascular access team does is that they help us have conversations with the providers when they think that peripheral lines versus PICC lines versus a midline is not appropriate. And currently, our vascular access team is the team that is trained for ultrasound guided IVs. So they are the really ones who are advocating to say a normal simple insertion might not be appropriate for this patient, and they're able to recognize the signs a little bit earlier, which is really beneficial.
So, with us being two organizations that can help lead some change, what are your thoughts on how we collectively, INS and AMSN, can work together to strengthen IV related competencies for med-surg teams?
I think we have a lot of fun places where we can partner, and I'm really excited about this conversation and some of the ones that we're going to continue to have in 2026 and beyond. We know that hands-on practice is the way to build the skill set the best. And at AMSN's convention last year, we had hands-on workshops as pre-convention sessions. And I think there's some really fun opportunities to make sure that the resources INS puts out are the resources that other organizations are using to teach. And I think we've got some shared speaker conversations happening about places where we can get together and have similar messaging moving forward. Any place, specialties are important. Nursing specialties are critically important, but the places we can partner we're just stronger every time we can do that. And so I think we really can work on those competencies and those skill sets and partnering with some of the equipment manufacturers to help get nurses access to the things that they need to practice the skills.
And I had a chance to look at the INS, the fundamentals of infusion therapy, those competencies and those modules, and I was so impressed. I thought they were excellent, and I think that they'd be something that'd be great for med-surg nurses, especially nurses who are inserting IVs and maintaining IVs, of course.
Absolutely. We highly encourage anyone listening, to utilize our resources that are available found at ins1.org. Those are available resources for you and your teams. Since we're talking about competencies and resources, INS also has competencies that are developed and you can replicate them. So what I mean by that is you would own the copyrights for the purchase of those competencies. So you can make copies and implement those competencies directly into your education programs within your organization. So it makes things a lot easier, and they're derived directly from the standards of practice. So they are updated with every new edition. So just throwing that out there as an additional resources. But, from an INS perspective, I think that's one way that INS can really help with these programs to ensure that competency is not only gained on the front end, but maintained. I think that's another piece to this, is making sure that our nurses are maintaining competency, because just because someone signed off initially doesn't mean that 2 years from now that they have that same skill set if they didn't have the experience to back them with that continued practice. So The next topic I want to talk about is staffing. So as we know, resources continue to be evaluated within our organizations. And within that, sometimes certain teams or staffing models can be cut or depleted. Some of our organizations are working with very limited vascular access teams, or maybe none at all. So a lot of the skill sets are falling directly onto med-surg nurses at the bedside, which makes things very complicated. I'm sure you all can speak to that. But what kind of guidance can you provide for these complex situations where they may not have the resources that they need?
I think, and it's always a difficult conversation, but I think it's really communicating what's a priority and what's a task and what's a priority. So making sure that we're not inundating our vascular access team inappropriately. We're not getting extra IVs for the sake of having an IV. We're not reaching out and taking up too much of their time when their priority is making sure that high risk patients are able to get the access that they need, depending on the organization, of course, and having realistic expectations with time frame. If you are contacting about something that's not a priority, realizing that it might not get done within the next hour, it might get done closer to 8 hours from now if it's something that's not an absolute need in that moment.
What are your thoughts on that, Kristi?
I think something Hayley talked about earlier is really important here, and that's how we work with our other interdisciplinary team members and make sure that the support folks we have around us are working to the highest extent of their scope, right? And if there's skills that can be taught to other clinicians that we're working with, let's make sure those have those skill sets and we can use them when needed. In some states, IV placement or IV removal is a skill that can be done by outside of the RN. And so that's something we should think about. We also really should think about who has what lines and when, and add that to our interdisciplinary rounds. It should be a regular part of that conversation. I think making sure we are all on board to what the priority is for the patient. And from a vascular access perspective, sometimes we lean towards more is better, bigger is better. And we know that that's not always what's best. And so helping
No.
helping like change the thought on that where we can, I think is a good idea
And
as well.
location of IVs. Don't even get me started on that.
I know you love
Stop
those
putting them in the
anti-cubitals.
AC.
I know you want them everywhere. AC or bust. That's the INS sticker, right? This is I'm gonna run Derek off the screen. I'm teasing, of course.
No, you're fine. That's hilarious. So, Hayley, if you could design an ideal IV therapy onboarding and competency pathway for new med-surg nurses, what are the key elements within that program that you'd like to include?
I think honestly it'd be the key elements in the modules for the fundamentals of infusion therapy with the addition of hands-on training by the vascular access team, because they
Mhm.
are the ones that are hands-on with these patients over and over again, and that's the best way for them to get to experience is by repetition over and over on real patients.
And I also want to add that there's no magic number of insertions that should deem you competent. Every situation is different. And if you have 10 easy accesses, that may not justify you to be truly competent to be practicing by yourself or inserting them by yourself, because there's always these complex situations that we get into and our clinicians may not feel supported or not have high success rates. So I would like to add to that list, if I may. um,
Yes.
Adding to that list, I say that we are individualized within our training programs to offer not only a certain number of insertions, but also evaluating the environment and the complexity of the insertion, right? Making sure that the experience within that training program really justifies a well-rounded practice for those device insertions is something I would like to add to it if I had a
I love
choice.
that. Yeah, no, that's a great call out.
Yeah. So, Kristi, let's talk about patients moving from the ED into your world. Oftentimes, we have patients that are coming from the ED who were stabilized or focused on a specific area or a focus assessment or a focus treatment plan within the ED. From an ED nurse myself previously, I understand that. But sometimes we have patients that arrive within the med-surg areas that have IVs that are not in the most ideal locations for long-term treatments or to justify the treatment plan that we have in place for when the patient is admitted. Can we talk about that and how can we better support our med-surg nurses for these scenarios or education that we can provide to prevent these situations from happening and or fix the situations when they arise?
Well, first of all, we love our ED colleagues, right? We all have these unique skill sets that drive us to our specialty area of choice. And we've got fantastic colleagues in the ED, we've got our fantastic colleagues in critical care, and we've got fantastic nurses who've dedicated to the
Absolutely.
specialty of med-surg. And so it's just, I always think it's so fun to think of the triad, right, of those three specialty organizations as adult care in a hospital. The answer, if there was one, it's communication. We have to talk to each other. Hey, we have to understand where each other's coming from. And we have to understand the patient's perspective, right? If I am a patient in an emergency department, I'll share my mom had a really big neurosurgery 2 years ago and had a couple of ER visits. And I'll tell you, it would have been really hard for me to explain to her why an IV that was put in at noon in the ER was no longer any good. 6 hours later on the med-surg unit she was transferred to, right? We've got to be able to have some communication to what's good, what's not good, why, and it's got to be between all of us. It's got to be between the clinicians. It has to be between the patient, and we have to think that through. I think it's about that long-term care planning. What is this access for? How long do we think we're going to need it for? And then we can make the appropriate decisions with all of that info in front of us.
Yeah, I think that is truly key. And then, education, right? Educating our nurses that are providing these services to determine what line is best and to advocate for the patient and pick the right sites and really know the specialty and understand how that device is going to affect the patient's outcomes, whether that be considering what we're putting through that particular device versus other external factors like the way that we move our arm that can cause mechanical phlebitis, which then can contribute to extravasation. So the list goes on and on. And the INS standards of practice outlines these key issues with current evidence. So I think it's important to educate and make sure that the individuals who are providing these services or skills to patients are truly knowledgeable about up-to-date practice and how to apply it at the bedside. So patient education is also a key area that, we all feel that is pretty important and is emerging the more that our patients have autonomy and can advocate for themselves, the better outcomes that we see statistically within the setting. So I know a great deal of what we do as nurses is educating our patients. But how can MedSurg be more empowered to educate consistent PIVC education?
I think in the med surg population, education is so complex, especially now in 2026, where patients have endless comorbidities and you want to educate on all of them so that they're not coming back to the hospital or they're able to manage it at home safely. So, a lot of education is a priority. But actually prioritizing what is important in that moment. Something that I think is the most valuable, focusing on education to make sure that med surg nurses are able to do it, is having a printout, having a leaflet so they can kind of check off the boxes of what exactly they need to educate on so that they know that they're not missing anything. Because it's pretty easy for things to slip through the cracks, especially in handoff, where if they've documented the education and they know that they've hit all those check marks, it's a lot easier to say, you know what, I did what I was supposed to do. I did the education that I needed to for
Yeah.
this patient so that they can advocate for themselves, especially if their line's burning, if they are having leaking, and they can get
Yes.
that tackled immediately.
Absolutely, because if they can identify that and notify the nurse, that really cuts down time from the time that the event occurred to the time that we implement interventions, right? Which
Exactly.
can actually save limbs. When
Yes,
we're looking at
prevent major,
extravasations,
major
some
complications.
medications can cause major, major damage, and including loss of limb and or death in some scenarios. It shouldn't be taken lightly, and thank you for that. No, I think it's really key to really give our nurses at the bedside the tools they need to successfully complete these skill sets so we can empower our patients.
Can I tell you
So
one of the
what?
things I'm really excited about in terms of this, which is
Yeah.
which is all of this ambient AI technology, right? So we're seeing this a lot across the country. There's a lot of companies who have built software that are listening to the conversations the nurse has with the patient. So what does that do? That forces the nurse to talk about their assessment out loud. So guess what the patient hears? I'm looking to see if there's redness at your IV site. Does it hurt? Is it tender to the touch? I'm looking for these things. And then the patient's like, hey, it wasn't earlier, but I heard that nurse say she was looking for redness. And so let me call that nurse back in the room because this redness is new and it wasn't there before. I think that type of technology is giving us such an exciting way to teach our patients all of this massive amount of assessment information that nurses have in their brains that's going to have to be verbalized for those types of technologies to work.
That's a wonderful key point. I think that is great. Technology is fantastic. I know we can be frustrated with the changes that occur whenever you implement new technologies, but my goodness, we have come a long way over the years.
Yes. And if as nurses, you got to roll with it.
You got to roll with it. You have
Yeah,
to know that change is part of what we do.
definitely. Definitely.
So, what joint initiatives that do you think could most benefit Med-Surg nurses between our two organizations looking forward?
Haley, I was going to let you go first.
So I know, Kristi, you're more familiar with all the initiatives that AMSN has right now. But I think one of the most exciting, I know we're doing it right now, but just the collaboration with INS, the podcast, and MedSurg Moments. I am so thrilled that I got to be a guest on this podcast. And I think that this is a good start of our collaborative efforts.
Great. Very excited about these partnerships. I think of them in two levels, right? One is how do we help nurses of all different skill sets and backgrounds and specialties get better in all sorts of ways? And then I think of it as from an organizational perspective, we're mirroring what we expect nurses to do or what nurses do all the time, which is partner in this way. We partner with our IV access teams, we partner with our emergency nurses and our critical care nurses. And so for us as national organizations to do that, I think it really demonstrates that same process and that same partnership and how we make things better. The more places where we agree as nurses and we can advocate for better staffing, better resources, better skill sets, better education programs, the more places we do that, the stronger and better we all are. And so I'm looking forward to those places that we get to do that. I'm also looking forward to getting to learn from your organization the things that are coming in the IV therapy access world, things we can maybe expect in the future, and looking forward to having some shared conversations about that.
Yeah, absolutely. And it that's mutual. We echo the sentiments from INS. We are excited for the collaborations and be able to learn more about our med-surg nurses to better serve and to create better alliances with everyone to make sure that our patients are at the forefront and making the best decisions and clinical pathways to get the best outcomes for our patients. So thank you both. As we wrap up today's episode, do you have any final thoughts before we conclude?
Only that thank you for having us on this podcast. This was a lot of fun and it was wonderful to talk to you guys.
It's great to hang out in this space. It's great to see faces and to have some good conversations and to figure out what's next steps. So thank you for having us. I know we'll have some more conversations this year.
Great. Well, thanks again. And as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.